The answer is right away. Because there is illusion of stability in heart failure, 20% of the stable patients had a primary event in paradigm HF, while there was no prior heart failure hospitalization. So they were looking stable, but they were not stable. 17% died during the course of the trial. And of stable patients who experienced a primary event, death preceded heart failure hospitalization in 51%. 60% of these deaths were sudden cardiac deaths. So that was the first event. It was looking stable heart failure, but not so stable. So ARNI should be started as early as possible. Do not wait till deterioration occurs, because deterioration might be the death itself. If you look at the guidelines also, in patients with HFrEF and class 2 to 3 symptoms, the use of ARNI is recommended to reduce morbidity and mortality. And use of ACE inhibitor is to be done when the use of ARNI is not feasible. And ARB is to be used only when the patients are intolerant to ACE inhibitor because of cough or angioedema, and the ARNI is not feasible. Now, is acute decompensated heart failure different from de novo heart failure? Yes, it has a lot of different pathophysiological mechanisms and clinical features as well. If you look at the patient characteristics, ADHF, acute decompensated heart failure, has older population, while de novo heart failure is usually in younger people. The baseline status is in ADHF worse. Laboratory findings show some morbidity, some comorbidities. There is a known history of underlying heart failure, while in de novo heart failure, there is nothing like that. Comorbidities like IHD, COPD, AF, diabetes, smoking, etc. History of intervention, more frequent, while here in de novo heart failure, it's less frequent. Trigger events, there is usually mistake in the medication, either poor compliance or there is a development of resistance, plus some diet-related changes, infections, vascular complications, interventions, drugs. These are the trigger events or precipitating events. While here in de novo heart failure, it's usually ischemia or valve incompetence. Inflammatory causes can be there, but they are less common. Clinical presentation is more or less same, but de novo heart failure is more likely to deteriorate in cardiogenic shock and acute pulmonary edema. Main pathophysiology for both is pulmonary and systemic vascular congestion, but in de novo heart failure, the hemodynamic derangement is more common and more acute.